Hey guys, welcome back to Neuronify, and we are finally ready to begin with toxicology section of FMT. And I'm so excited to begin the session. But before that, I want to discuss punch drunk syndrome with you people. So after discussing punch drunk syndrome, which was remaining in the last session, then we'll be starting with toxicology, general toxicology. So what is punch drunk syndrome? What are the synonyms? It is also called as dementia pugilistica and also called as chronic traumatic encephalopathy. Either it is called as dementia pugilistica or chronic traumatic encephalopathy. Now, what are the causes? It occurs due to repeated blows to the head, multiple concussions, recurrent minor traumatic brain injuries. So, in simple term, whenever there are repeated blows to the head, repeated minor injuries to the head, multiple concussions means disruption in the brain function due to continuous movement of the brain, or say long-term participation in contact sports. So, these are the causes of your punch drunk syndrome. Moving ahead, now what are the risk factors? Risk factors are boxing, most common classical association. It is associated in, it is seen in boxers, wrestling, football, martial arts, repeated physical assaults, and long sports career. So these are the risk factors: your boxing, wrestling, football, martial arts, repeated physical assaults, and your long sports career. In boxers, we find this very commonly, and so it is also called as boxer's disease or boxer's syndrome. Fine. Moving to pathogenesis. Repeated trauma leads to injury to neurons, abnormal accumulation of tau protein, progressive degeneration of brain tissue, and brain atrophy develops over time. So, obviously, if there is going to be continuous injuries happening to the brain, the neurons are going to get damaged. Okay, so that repeated trauma leads to the brain atrophy, which develops over time. Then what are the clinical features? There are cognitive symptoms. What do we mean by cognitive? Anything which is related to the thinking and understanding ability of that person. So that is why we say what are the cognitive symptoms. So memory loss, poor concentration, confusion, and reduced judgment. Talking about behavioral behavioral symptoms: irritability, aggression, mood swings, depression. Then motor symptoms: tremors, slurred speech, unsteady gait, Parkinsonian features. So these are nothing but your behavioral, motor, and cognitive symptoms. Now, what are the advanced symptoms? Dementia, then severe personality changes and difficulty in daily activities. So, what are the gross pathological changes? Cerebral atrophy, enlarged ventricles, brain shrinkage, and degeneration of specific areas. Obviously, as the time passes, brain atrophy is going to happen. So, why cerebral atrophy is observed, enlarged ventricles are there, brain shrinkage, which is your brain atrophy. Then, moving to microscopic findings: neurofibrillary tangles, tau protein deposition, and neuronal degeneration. Then, what is the diagnosis? Clinical history of repeated head trauma, then neurological examination, imaging, which is MRI, and definitive confirmation is classically by pathological examination. Now, what is the medico-legal importance? Seen in occupational and sports injuries, important in assessing permanent neurological disability, relevant in compensation and sports safety cases, and it helps establish long-term effects of repeated head trauma. So, medico-legally, it is going to help us in differentiating between the permanent neurological disability and your other differential diagnosis. So basically it is seen in occupational and sports injuries. So these points help us to quickly confirm the diagnosis of punch drunk syndrome. So yeah, now what is the prevention? Use protective headgear, limited repeated concussions, early medical evaluation is must, and adequate recovery before returning to sports. So body must recover completely. Now, so in short, summarizing what is punch drunk syndrome, we have to define it. Fine, we'll define it. What is punch drunk syndrome? It is a syndrome in which there is progressive brain degeneration due to repeated head injuries, especially in boxers, leading to cognitive, behavioral, and motor impairment. So this was all about your punch drunk syndrome, and yeah. So we are good to go with toxicology part now. So general toxicology, our very first question is, what are the duties of doctor in poisoning cases? Fine. So what are the duties of us in poisoning cases? Number 1, treatment. The foremost duty of the medical officer is to treat the patient and not to allow him to die because of poisoning. Obviously anything, not just poisoning, but in every disease you have to treat the patient and not just let the patient to die. The treatment should be given on specific lines when the nature of the poison is known, and it should be on general lines of treatment in the case of unknown poisoning. So if you have if you know what the poisoning is, you can start your specific line of treatment, and if you don't know what the poisoning is because of, then you can start with general line of treatment. Though a GP, that is general practitioner, can choose his patient, but it is unethical to refuse a patient in emergency. If brought dead, inform police and send body for postmortem. Remember, in poisoning cases, postmortem is compulsory whenever you get dead body. All the preliminary data should be recorded, including name, age, sex, address, brought by, brought from, brought at, time, date, place, place of examination, consent of the patient or guardian, and the marks of identification. History, the details of the nature of the poison, time of consumption, time of onset of manifestations, nature of the manifestations, nature of vomitus, any typical smell, any treatment received, history of drug hypersensitivity, and motive of poisoning should be recorded. Now, in examination, general examination, level of consciousness, behavior of patient, temperature, pulse, BP, respiration, condition of skin, whether sweating, color, if cyanosis present, condition of pupil, breath smell, vomitus stains on clothes. And what about systemic examination? Detailed examination of all systems. Then judge whether poisoning is suicidal, homicidal, or accidental. Information to authorities. An institution or public hospital has to inform police all cases of poisoning. A private practitioner is not bound to inform to police cases of suicidal and accidental poisoning. He should ask the relatives to inform if they so desire, but if inquired by the police magistrate or court, he has to furnish the information. Failure to do so is punishable under 202 IPC, 6 months of imprisonment, fine, or both. And giving false information is punishable under 177 IPC, which includes 2 years of imprisonment, fine, and or both. So, as a whole, just remember, what are the duties? You have to give treatment, then you have to do PM, you have to inform police, you have to take proper history of the patient, you have to examine the patient properly, and you have to give information to authorities. Now, cases of homicidal poisoning have to be informed. As per section 39 CRPC, a medical officer is bound to inform all the cases of homicidal poisoning. Non-compliance is punishable under 176 IPC. In case of accidental poisoning from food, water, hotel, or in industry, the public health authorities should also be informed so that the precautions can be taken for public health safety. Then, in homicidal poisoning, always and always admit the patient, always consult a colleague for treatment, avoid any further chances of poisoning. The food and the drugs to be given only by nursing staff, no friend or relatives permitted to see the patient. If admission of the patient is not possible, appoint 2 nurses to look after him at his residence. If nurses can also not be appointed, 2 close relations are taken in confidence and their names entered in records and informed to the police. If the patient is conscious, he is informed of the situation so that he can take precautions. So these are the points under homicidal poisoning. In all cases of poisoning, observe the patient for at least 24 hours. If the patient turns serious, inform the police. If the patient is likely to die, arrange for dying deposition or dying declaration. If the patient dies, death certificate should not be issued. Inform the police and the body should be sent for the PM examination. Material for chemical analysis. It is legally obligatory for the medical officer to send samples of gastric lavage, blood, urine, feces, and vomitus, whatever available, for the chemical analysis. The suspected food, drink, drugs, utensils, bottles, and soiled clothes, if brought, should be sent for chemical analysis. So it is corroborative evidence. What is corroborative evidence? Suspected food and drinks and drugs, utensils, everything. We send it for chemical analysis. Failure to preserve the samples may render him liable to be charged under 201 IPC, 7 years of imprisonment and fine for causing disappearance of evidence. Now, what about records? Detailed records should be maintained of complaints, examination condition, progress, prognosis, and treatment. Then, what about opinion? Should be based upon evidence and not on the history or guesswork. Opinion about the nature of the poison should only be given after receiving the report of chemical analysis. Now, what are the legal duties of a doctor? Informing cases of homicide, sending samples for chemical analysis to furnish information to police when asked. So, in short, remember, you have to write about the nature of the poisoning. If it is homicidal, what precautions you are going to take. If it is accidental, then what would be the precautions, what would be the pattern of informing, or private practitioners may or may not inform. So these are the points in poisoning part, basically duties of doctor part. But legal duties are, in short, informing cases of homicide, sending samples, and the to provide police with every information. So this was all about the duties of doctor. Moving to next question. What are the chelating agents in treatment of poisoning? Very important question. But very first, what are chelating agents? These agents interact with poison to form an inert compound, or say complex, which is then excreted from the body. These agents are primarily used in heavy metal poisoning. These agents with metal ions forms a ring structure within their molecule, and that's why the name chelating is derived from ring. Okay, the compound holds the metal like a crab's claw. So basically, this agent which we are going to give to the person, or which we are going to use in poisoning cases, it chemically, or say at the molecular level, it forms a ring, and that ring grabs the metal poisoner. So that is why those are said to be chelating agents. Now, what are the examples? Bile, succimer, disodium editate, penicillamine, desforioxime, calcium disodium editate. So these are few examples. Now, what is British anti-levisite, which is bile? So it is also called as dimercaprol or dimercaptopropanol. Very important. What are the features? It is an oily, pungent smelling liquid developed during Second World War by British as an antidote to the arsenic war gas levisite. So in arsenic poisoning, we can use bile, which is oily, pungent smelling liquid. That is why it is called as British anti-levisite, because it was discovered by British. Now, what is the mechanism of action? It has got two SH groups. SH means thiol groups. So the two SH group binds to those metals that produce toxicity by interacting with sulfahydryl containing enzymes in the body. So what they do, they have got two SH groups, fine, and these SH group, interact with the sulfahydryl containing enzymes in the body, fine. So Bal will combine with these metals forming Bal metal complex, thus dislodge the metal from acting site. So the SH groups are going to interact with the metal, and then they're finally going to form the complex, Bal metal complex, which is which obviously is going to lead in dislodging of the metal from the acting site, fine. What are the indications? Bal is useful against metals that interfere with sulfahydryl enzymes in the body, such as arsenic, mercury, bismuth, copper, antimony, and nickel. So in these type of poisoning, we use what do we say, British anti-levisite. So the two SH groups binds to those metals that produce toxicity. So what they're trying to say, remember, when just think, when we use Bal as, or say Bal, whatever, British anti-levisite as an antidote, whenever there is poisoning which interacts with the sulfahydryl enzymes of the body. So we have got some sulfahydryl enzymes in our bodies, and if we get that particular metal poisoning which interferes with those sulfahydryl poisoning which are present in our body, then and then only we use Bal, because the SH group of Bal is going to interact with the sulfahydryl enzymes also, and they are going to dislodge the metal from the acting site. So this is all about the mechanism. Understand, we use Bal when we get to know about the poisoning due to a substance which interacts with the sulfahydryl enzymes in the body. Now, what are the contraindications? Bal is contraindicated in iron and cadmium poisoning because Bal iron or Bal cadmium complex are toxic. Remember, iron and cadmium poisoning, it is contraindicated. What is the dose? Bal is administered intramuscularly as 5 mg per kg stat, followed by 2 to 3 mg per kg every 4 to 8 hours for 2 days, and then once a day for 10 days. Stat means immediately. So 5, whenever you get to inquire a patient, you'll immediately give 5 mg plus 5 mg per kg, followed by 2 to 3 mg per kg every 4 to 8 hours, and that is for 2 days, fine, and then once a day for 10 days. Now, what are the adverse effects? Tachycardia, increase in heartbeats, vomiting, tingling and burning sensation, cramps and sweating. So this was about the BAL, British anti-levisite. Remember to write features, mechanism of action, indications and contraindications, and dose, even adverse effect in every antidote. Number 2, Saxima, also called as dimecaptosuccinic acid. The agent is similar to Bal in chelating properties. It is less toxic than Bal and orally effective. It is used against arsenic, mercury and lead poisoning. So in Saxima we use it in arsenic, mercury and lead poisoning, and Bal we use it in your arsenic, mercury, copper, then bismuth, antimony and nickel, fine. So now we'll be seeing about the features. So only one point is mentioned regarding Saxima, ki the synonym is dimecaptosuccinic acid and the agent is similar to Bal in chelating properties. It is less toxic and used in arsenic, mercury and lead poisoning. So no features and indications are given here, but yeah, we'll move to the next antidote then. Next antidote is calcium disodium editate. What are the features? It is not absorbed from GIT. It should be used as IV, or it should be used as IV because intramuscular injection is painful. So as IM is painful, you have to give it IV. It is distributed extracellularly. Okay. Now, what is the mechanism of action? What is the mechanism of action? It chelates metal. It chelates metal extracellularly and removes the metals from the body by exchanging with calcium. So it is going to chelate the metal outside the cell, and it is going to remove the metal from the body by exchanging with calcium. It is rapidly excreted in urine by glomerular filtration, carrying the toxic metal along with it. The compound is not metabolized in the body. Now, what are the indications? We use it in lead, zinc, cadmium, copper and manganese poisoning. And contraindications: in cases with raised intracranial pressure where fluids are restricted. So you cannot give it in patient who is suffering from increased intracranial pressure. What is the dose? 1 gram is diluted in 200 to 300 ml in saline or glucose solution and infused intravenously over 1 hour twice daily for 3 to 5 days. So doses: 1 gram is diluted in 200 to 300 ml in saline or glucose and given IV over 1 hour and twice daily for 3 to 5 days. What are the adverse effects? Remember, 1 gram is diluted in 200 to 300 ml saline. What are the adverse effects? Renal damage, acute febrile reaction, anaphylaxis and thrombophlebitis. So this was about the calcium disodium editate. Fine, we learned about BAL, we saw one point regarding Saxima, and we also learned about the calcium disodium editate. Now we'll move towards penicillamine, also called as cuprimine. What are the features? It is dimethylcysteine obtained as a degradation product of penicillin and available in D isomer and L isomer form. So it is dimethylcysteine, fine, and it is obtained as degradation product. The D isomer is used because I isomer is more toxic and produces optic neuritis. So D isomer is used to prevent the optic neuritis caused by the remaining isomer. It is absorbed from after oral administration, metabolized in the body and excreted in urine and feces. So we give it orally, and it is also metabolized in the body and it is excreted in urine and feces. What is the mechanism of action? Exact mechanism is not known yet. And what are the indications? In copper poisoning, it is drug of choice. Mercury poisoning, alternative to bile, and chronic lead poisoning, Wilson's disease, cystinuria, and cystine stones. So in that we used penicillamine. It is your drug of choice in copper poisoning. Remember. What is the dose for copper and mercury poisoning? 1 to 1.5 grams per day in divided doses, and for Wilson's, 0.5 to 1 gram per day in divided doses. Just remember about copper and mercury, 1 to 1.5 gram per day in divided doses. 1 hour before meals or 2 hours after the meals to avoid the chelation of dietary metals. So basically just remember about the copper and mercury poisoning, it is important. Now what are the adverse effects? Cutaneous reaction, febrile illness, nephrotoxicity, bone marrow depression, anorexia, nausea, and loss of taste. So loss of taste is there, nausea, anorexia, bone marrow depression, nephrotoxicity, febrile illness, and cutaneous reaction. So this was about the adverse effect due to penicillamine. Now what is desferrioxamine? I think you people know this. We use it in iron poisoning. So ferrioxamine is a long chain iron containing complex obtained from an actinomycete. Chemical removal of iron from it yields desferrioxamine that has great affinity for iron. So if administered orally, little amount is absorbed. It binds with iron present in GIT and prevents its absorption. If administered parenterally, desferrioxamine is partially metabolized and rapidly excreted in urine. So I think you people got this. We obtain it from removal of the iron from the ferrioxamine, which is long chain iron containing complex. Now what is the mechanism of action? Desferrioxamine molecule turns around the ferric ion and forms a stable non-toxic complex that is excreted in urine. 1 gram of desferrioxamine is capable of removing 85 milligrams of elemental iron. It removes loosely bound iron and iron from hemosiderin and ferritin, but do not remove iron from hemoglobin or cytochrome. So remember, it does not remove the iron from HB, that is hemoglobin or cytochrome. Now what are the indications in iron poisoning, acute iron poisoning, and transfusion siderosis? So in these conditions we give desferrioxamine. Now dose. It is the drug of choice in iron poisoning. It should be given IM 0.5 to 1 gram repeatedly 4 to 12 hours. In severe life-threatening poisoning or patient with shock, he should receive intravenous desferrioxamine, which is 15 milligram per kg per hour with a maximum daily dose up to 360 milligram per kg or up to 6 gram in total. So just remember about the dose. 2 points. Number 1, route of administration is intramuscular and the dose is 0.5 to 1 gram repeatedly 4 to 12 hours. So this was about the dose. Now adverse reactions or adverse effects: fall in BP, bradycardia, then itching. Fall in BP is decrease in the blood pressure, itching, urticaria, rashes, abdominal pain, diarrhea, and muscle cramps. Okay. So this was all about. Fall in BP is your hypertension, not bradycardia. I was going to say bradycardia, but fall in BP is your hypertension, and fall in heartbeats is your bradycardia. So yeah, we learnt about desferrioxamine. Now we are good to go for another question. Antidotes in this. Yeah, so this question is you might get confused between chelating agents and antidotes. Okay, so remember, in this question they asked about chelating agents in treatment of poisoning, and the next question is about antidotes. So this is kind of confusing. So what are antidotes? Antidotes are those substances used to counteract or neutralize the effects of poison. So table provides antidotes that should be available in emergency room. Table 32.84 represents poisons and their antidotes. So basically antidotes are the substances used to counteract or neutralize the effects of poison. Okay, and what are chelating agents? Chelating agents are those substances which interact with the poison and they form the inert compound or complex. So I want you people to understand this concept very clearly, that chelating agents can be used as antidotes. Okay, now what are classification? What is the classification of antidotes? We have got 4 things in classification: physical, chemical, your physiological, and universal. Fine. So whenever, this is very important question, so you have to make a table or flowchart regarding the classification, in which you'll be writing about physical, also called as mechanical or non-specific antidotes. So these antidotes retard the absorption of poison by mechanical action. Example: activated charcoal, demulcents such as milk, starch, egg white, egg albumin. Activated charcoal acts mechanically by absorbing the poison and retaining it within its pores. Demulcents are the substances that form a protective coating on the gastric mucosa and thus retard the absorption. So activated charcoal is going to be a mechanical barrier, or say mechanical adsorbent. It is going to adsorb It is going to retain the poison on its surface. And what are the demulcents? These substances are going to form a protective coating on the gastric mucosa. Remember the examples: activated charcoal and your milk starch egg white. What about chemical antidote? These compounds counteract the action of poison by neutralizing the poison or forming harmless or insoluble components. So, example, in corrosive alkali poisons, weak vegetable acids like citric acid, lemon juice may be used. So, in corrosive alkali is a base, so why neutralization reaction may occur, so you have to use weak vegetable acid. Fine. What about physiological or pharmacological antidote? These agents act on the tissues of the body. These substances work either in one of the following ways. So, number one way, reduces the toxic conversion of poison. For example, ethanol is used as an antidote in methyl alcohol poisoning because ethanol inhibits the metabolism of methanol to toxic metabolites by competing for the same enzyme. So, in methanol poisoning or say methyl alcohol poisoning, the treatment is itself ethanol. Why? Because ethanol inhibits the metabolism of methanol to toxic metabolites, and so why there is a zero formation of the toxic metabolites. Competition at the receptor site. Some antidotes are capable to compete with the poison and displace the poison from the specific receptor site, thereby antagonizing the poisonous effects completely. Basically, these antidotes act as antagonists. For example, in opiate poisoning, naloxone is used. Then naloxone antagonizes the effect of opiate by acting at opiate receptors. So basically, it blocks the receptors for opium itself. Now, blocking the receptor site, either there is competition at the receptor site or there is complete blockage of the receptor site. Now, we are going to study about the blocking of the receptor site. Some antidotes are capable of blocking the receptor site acted by poisonous substance, thereby blocking the poisonous effects of substance. For example, in OPP, atropine is used. So, organophosphorus acts at muscarinic receptors, producing toxic effects. So, administration of atropine will block the effects of organophosphate. This was about the physical, which is your mechanical, then chemical, and your physiological antidote. Now we are going to read some examples. What are the antidotes? Examples: activated charcoal, amyl nitrate, antivenin, calcium chloride, desferoxamine. Then see, desferoxamine is chelating agent. So chelating agents come under antidotes section. Okay. Now, what are the recommended antidotes? See, this table is very important for MCQ purpose also and for your theory exams. So what is the antidote in paracetamol poisoning? Acetylcysteine. Cyanide poisoning, amyl nitrite. Organophosphate, atropine. Iron, desferoxamine. Methanol, ethanol. Benzodiazepines, we give flumazenil. Insulin, we give glucose. Opioids, we give naloxone. Copper, D-penicillamine. And central anticholinergics, we give physostigmine. So this table is very important and just go through it once. Now what is called as universal antidote? It is an absolute antidote and had only historical importance. The composition of universal antidote is provided in the table. So this is one of the most frequently asked SAQ on detailing and components of the universal antidote. So universal antidote has got three things, remember. TMC, okay, or tannic acid, magnesium oxide and charcoal. So remember TMC. What is TMC? Tannic acid, magnesium oxide and charcoal. Now, tannic acid, we have got one part of tannic acid, one part of magnesium oxide and two parts of charcoal. In total, we have got 4 parts. Tannic acid 1 part, magnesium oxide 1 part and charcoal is 2 parts. So, tannic acid precipitates the alkaloids, certain glycosides and metals. Magnesium oxide neutralizes acids because it is itself a base, and charcoal absorbs poison. So we all know charcoal is an adsorbent, magnesium oxide is a base, so why it is going to neutralize the acid, and tannic acid is going to precipitate the alkaloids and certain glycosides. So this was the composition of your universal antidote. Next question: what are poisons? Classify them. What are the factors modifying actions of the poisons on the body? So up till now we learned about the chelating agents, the antidotes, but now we are going to classify the poisons. So we'll start with our classification. Poisons can be classified as it is based on type of action and medico-legal classification. So upon the action, we have got 6 types: corrosives, irritants, neurotoxic, cardiac, respiratory, and miscellaneous. So based upon the action, which means what action they are going to perform, we have classified poisons into 6 parts: corrosives, irritants, neurotoxic poisons, cardiac poisons, respiratory, and miscellaneous. Okay. So in corrosives, we have acids, alkalis. Okay. We also have alkalis in corrosives, not only acids. So talking about acids, we have got inorganic, organic and vegetable acids. Inorganic acid, sulfuric acid, king of acids, hydrochloric acid and nitric acid. What about organic? Acetic acid, salicylic acid, oxalic acid and carbolic acid. Then vegetable, hydrocyanic acid, cyanides and potassium cyanate. So this was about the examples of acids. Now alkalis, we have got hydroxides and carbonates. Hydroxides of sodium, potassium and ammonium, and carbonates of sodium, potassium, ammonium. These were the examples of corrosives. Now, what about irritants? Again, in irritants, we have got inorganic, organic, mechanical irritants. Inorganic, non-metals and metals. In non-metals we have got phosphorus, boron, fluorine, chlorine, bromine, iodine. In metals we have arsenic, lead, mercury, copper, iron, zinc, manganese, magnesium, thallium, and radioactive substances. What about organic irritants? In vegetable we have castor oil, croton oil, Abrus precarius, marking nut, calotropis, ergot. In animals we have got snake bites, scorpion bites, spider bites, then cantharides and poisonous insects. In mechanical, powdered glass, diamond dust, dry sponge, hair pins, needles and needles. So this was about the irritants. Coming to neurotoxics. So cerebral, spinal, peripheral. What about cerebral? Narcotic or somniferous, that is sleep producing. Inebriants are capable of intoxicating. Deliriants, the one who cause delirium. And yeah, in narcotic again we have got opium, morphine, codeine, noscapine, etc. What about spinal? I'm so sorry. What about inebriants? Inebriants basically alcohol, anesthetic agents, fuels, sedatives and hypnotics, and insecticides. So in insecticides also you can write DDT and endrine. And what about deliriants? The one who cause delirium. Who cause delirium? D for deliriants, D for datura. Cannabinus, atropa, belladonna. So datura, cannabinus, atropa, belladonna. These names na come in association every time, so you can remember by that. Then what about spinal? Excitants and depressants. In excitants we have got nux vomica, anise alkaloid strychnine. Depressants, Lathyrus sativus, kesari dal, and gelsemium, which is jasmine. Peripheral, conium and curare. Okay. Now what about cardiac poisons? Aconite, digitalis, oleander and tobacco. Respiratory, also known as asphyxiants, carbon monoxide, carbon dioxide, SO2, H2S, NH3, ammonia, phosphine, war gases and sewer gases. Miscellaneous, we have analgesics and antipyretics. So this is very big classification. Just remember, classification based upon the action. Corrosives, irritants, neurotoxic, cardiac, respiratory and miscellaneous. Yes. Now, we'll learn about the medico-legal classification. So what is the medico-legal classification? Again, medico-legal is classified into 9 parts. And based upon action, we have got 6 parts, and based upon the medico-legal classification, we have got 9 parts. So the commonest cause of poisoning in India is organophosphates. However, in North India, the commonest suicidal poison is aluminium phosphide. So suicidal poison is aluminium phosphide, and homicidal would be, or accidental would be, organophosphate. So for the medico-legal purpose, poisons are classified into 9 groups: suicidal, homicidal, accidental, stupefying, abortifacients, cattle poisons, arrow poisons, food poisoning, and drug dependence. So number 1 is your suicidal poisoning. Characteristics, features of an ideal suicidal poison: it should be cheap, it should be easily available, it should be highly toxic, either tasteless, colorless and odorless, or the same should be pleasant, should be capable of being easily taken with food or drinks, then should lead to calm, quiet and pleasant death. So these are the points regarding suicidal poison. So basically a person's needs should be fulfilled by a suicidal poison without causing any pain to that person. So in this way you can write, it should be cheap so that everyone could afford this. Then there is no ideal suicidal poison. The near ideal suicidal poisons are opium and barbiturates. So poisons which are commonly used in India are insecticides, arsenic, aconite, cyanides, carbolic acid, which is your phenol, barbiturates, opium, oleander, carbon monoxide and sulfose. What about homicidal poisoning? What are the features? It should be cheap, easily available, highly toxic, should be odorless, colorless, tasteless, should be capable of being administered with food or drinks, should be fast acting, or the symptoms should be so much delayed that there should be an opportunity for the culprit to run away. Then the features produced should preferably resemble a natural disease, that is to avoid suspicion. Then there should be no antidote available, should be fast metabolized in the body so that it is not detected on PM examination, it is not detected on chemical analysis. So there is no ideal homicidal poison. So the near ideal homicidal poisons are thallium and fluoride. Then the common poisons used for homicidal purposes are corrosives, carbolic acids, oxalic acid, cyanides, arsenic, lead, snake venom, insulin, adrenaline, potassium chloride, alcohol, opium, insecticides, strychnine, aconite, oleander, blah blah blah. So just remember, common are oxalic acid, cyanides, arsenic, lead. Okay. What about accidental poisons? So I think you people got about homicidal poisons. Anything which can be, which can work in the side of the culprit or the accused, that would come under the homicidal poisoning. It should be cheap also, then he should also get time to run away, then in PM findings also the poison should not be easily identified. So these are the features regarding, and we all can write this. Just remember the examples: oxalic acid, cyanides, arsenic, lead. Moving towards accidental poisoning, the one which occurs due to accident, unintentional. Due to keeping insecticides at home or fields, at place of work, carelessness, then quack remedies, bite by snakes or scorpions, insects. So these can occur with any of the listed poisons, and it can be described as how a particular poison could lead to accident. Okay? The poison, the condition should describe these 2 points, ki how a particular poison could lead to accident, and number 2, depending upon the profession and social status. Example, in industry, in agricultural fields, in labs, among porters, in children, in addicts at home, food poisoning, etc. So you have to think about the profession also, and you have to think about the question ki how that poison would be caused due to an accident. So if these 2 conditions are fulfilled, then yes, you can declare it as an accidental poisoning. Now, what are stupefying poisons? Literally, stupefying means to render stupid, to make someone stupid. So these are the poisons which alter the consciousness of the person and are commonly given for the purpose of rape, robbery, dacoity, theft, child lifting, and for removal of organs for transplantation. So datura, cocaine, alcohol, arsenic cigarettes, cannabis preparations, bhang, charas, ganja. Bhang is obtained from the leaves of plant. Charas is also known as marijuana. It is the secretion from the stem and leaves of the plant. Ganja is female flowering tops. What about abortifacients? These are the poisons which are used for inducing criminal abortion. Abortifacients like arsenic, lead, ergot, aconite, corrosives, oleander, castor oil, croton oil, calotropis. What about cattle poisons? These are the poisons used for killing cattle like Abrus precarius, snake venom, strychnine, aconite, oleander, etc. What about Abrus precarius? See, Abrus seeds are powdered, maybe mixed with datura or opium. A paste is made. The paste is drawn into needles known as sui, and the suis are dried, put to bamboo stick, and the stick is hit on the buttock. This leads to the local and remote poisoning and the death of the cattle, also called as sui poisoning. The local manifestations resemble viper snake bite. So the local manifestations or symptoms appear as viper snake bite, but that is not snake bite. It is your Abrus precarius. Abrus seeds are mixed with datura and opium. What about arrow poisons? The poisons which are commonly applied on the arrow, like Abrus, strychnine, aconite, curare, calotropis, and snake venom. So these were the poisons, classification of poisons based upon the medical legal importance. Suicidal, homicidal, accidental, stupefying, abortifacients, cattle poisons, arrow poisons, food poisoning, and drug dependence. What about your based on action? 6 groups: corrosives, irritants, neurotoxic poisons, cardiac, respiratory, and miscellaneous. Now we are moving to the next point. What are the factors which influence the action of poisons? What makes the poison work as a poison? Okay. Number 1, dose with exceptions. Number 2, form of the poison, in which form you are administering, whether it is physical, chemical combination, or mechanical combination. Now, what is the route of administration? What are the effects of route? Effect of change of the route. Now, what are the general conditions like age, deceased conditions, effect of sleep? Then, yeah, so these are the 4 points which affect the killing capacity, or say poisoning feature, poisoning characteristic of that particular poison. Number 1, dose. Normally the action of the poison is directly proportional to the dose taken. More the dose, more would be the action. So arsenic in high doses causes immediate death due to narcotic action. Sometimes the effect may not be severe due to vomiting caused by large doses of the poison. Now, what are the exceptions? Idiosyncrasy. This is the inherent hypersensitivity to a particular drug or agent, so that even a small dose may cause death. So these are the exceptions for the dose. Cocaine, morphine, iodine, bromine, strychnine, fish, milk, etc. What about allergy? It is acquired hypersensitivity due to the formation of antibodies during the previous administration of the same agent, like penicillin, other protective serums. Tolerance: certain agents on repeated administration are tolerated by the body, so that a higher dose is required to produce the original effect. So in tolerance, we require more dose. In sensitivity and your allergy, and in allergy and your idiosyncrasy, we are going to small doses also sufficient. So in tolerance, we have got alcohol, morphine, pethidine, cannabis, then arsenic, strychnine, opium, nicotine. The repeated and long continued use of these substances results in the addiction and drug dependence. What about synergism? That is potentiation. The effect produced due to the combination of substances is more than the sum of the individual effects. So if you are going to combine the 2 things together, obviously the effect is going to be more, like alcohol with barbiturates, antidepressants, anticonvulsants, tranquilizers, antihistaminics. Cumulative poisons: certain poisons keeps on accumulating in the body, and then suddenly there is a marked response. So accumulation of poisons in the body results in the marked response. Now, with the change in dose, the entire action of the poison may change. Example, arsenic in high doses is narcotic poison. Copper sulfate in high doses is not that poisonous due to vomiting caused. Okay. So yeah, so what were these? These were the exceptions for your dose point. Now we are going to learn about the form of poison. Physical state, chemical combination, mechanical combination. Yeah, so these 3 things are there. You people know now, we are learning about the factors influencing the action of the poisons. Okay, so what are the factors which influence the action of the poisons? And under that we have got dose, form of the poison, route of administration, general condition, of the body. So we have got 4 things under that. First thing we learned, that was the dose. We also learned about the exceptions. Now we are going to learn about the form of the poison. Then afterwards we'll be reading about the route and the condition. So these are the factors which influence the action of the poison. Just listen it carefully. No need to write so much in detail. Just listen it for the purpose of understanding. Now, what are the forms of poison? Number 1, physical state. The poison in gaseous state is more poisonous than liquids, which are more poisonous than solids. So gas followed by liquid followed by solid. Generally, concentrated poison is absorbed rapidly. This was about the physical state, whether your poison is going to be gaseous one or liquid or solid. What about chemical combination? Pure arsenic and mercury are not poisonous, while their salts are extremely poisonous. So that is about the chemical combination. Some chemicals are less poisonous, like mercurous chloride than mercury chloride, barium sulfate than barium nitrate. A combination of chemicals may either be less or more effective. Then what about less effective ones? Who are less effective ones? Acids and alkalis. Acids and alkalis and water. Strychnine plus tannic acid or silver nitrate plus HCl. Who are more effective? Copper arsenide with lead carbonate. The poison is more soluble in gastric HCl. Also, potassium ferrocyanide with potassium ferricyanide is more poisonous, being more soluble in gastric HCl. So these are just points regarding who is going to be less effective, who is going to be more effective under your chemical combination. What about mechanical combination? The mechanical substances physically hinder the absorption of the poison, like charcoal, oily substances, bulky foods. However, oils dissolve the phosphorus, so hasten its absorption. Now, absorption of poison is slow on full stomach, remember. So it is very slow on full stomach. What about the route of administration? What is the route? Poisoning, this is the third point in your factors which affect the action of poisons. Route, poisoning through inhalation is more effective than IV, than IM, and than any other parenteral, and then oral. So number 1 is inhalation, number 2 is IV, number 3 is IM, number 4 is oral. Poisoning through mouth is more effective than rectal poisoning. And lastly, we have got rectum. Change in route, a change in route may cause change in the action of poison, like snake venom is effective only when injected into the body and it is digested on swallowing. Cocaine on ingestion, it is deliriant, and on injection it acts as a local anesthetic. So if you're going to administer it by injection, then it is going to act as local anesthetic, but if you're going to ingest it, that is to take it orally, then it will act as deliriant. Curare, on ingestion it is inert, on injection it is highly toxic. So route of administration is also very important. It also plays a role. Now what is the general condition of the body? Age, normally the same dose per kilogram body weight is more effective in children and elderly. Opium is much more poisonous in children. Atropine is better tolerated by children. Then diseased condition, normally if organ is diseased, the effects are more, like in case of liver pathology, morphine is more poisonous. In case of your renal damage, mercury is more poisonous. In head injury or raised ICP, morphine is dangerous. ICP, intracranial pressure. Some poisons are tolerated better during disease conditions like digitalis in heart failure, strychnine in paralysis, cyanide in chlorhydria, that is depletion of HCl, atropine in OPP, sedatives in mentally ill patient, and opium in tetanus. So even poisons are tolerated in diseased conditions also. What about sleep? Since during sleep the body metabolism is minimum, the effect of poison is less if given during sleep, or if the person goes to sleep immediately after taking the poison. So these were the points regarding your poisons, types of poisons. Remember, we have classified. We'll just quickly revise this. This is a very big question. You don't need to write these many points in your answer, but broadly you are going to classify poisons into 2 parts based upon the action and based upon the medical legal classification. Based upon the action we are going to have 6 groups, and based upon the medical legal action we are going to have 9 groups. In 6 groups I'll be writing about corrosives, irritants, neurotoxic poisons, cardiac ones, respiratory and miscellaneous and their examples. And in my 9 groups I'll be writing about your suicidal, homicidal, stupefying, accidental, abortifacients, cattle poisons, arrow poisons, food poisoning and drug dependence. Then I am going to also write about the factors. What were the factors, or what are the factors which influence the effect of the poisons, or say action of the poisons. So I learned, or say we learned about the 4 factors: dose, form of poison, route of administration and general condition. So under this point I am going to explain each and every point. What about the dose and their exceptions, what about the physical state, chemical state and the mechanical state, what about the route of administration, how it is going to affect when given by when given parenterally, how it is going to affect when given orally, then what are the general conditions, what would happen in child, what would happen in an old age person. So these are the things we learned in this question about poisons. And yeah, I hope you people understood the session. This was about the general toxicology. We learned about questions in general toxicology. We learned about the duties of the doctor. We also learned about the antidotes and chelating agents. So remember about antidotes. Quickly I'll be revising because this table is very important. Antidotes and their poisons. So in paracetamol poisoning, you are going to give acetylcysteine. In cyanide poisoning, you are going to give amyl nitrite. In OPP, atropine, iron, desferrioxamine, methanol, ethanol. In benzodiazepines, flumazenil. In insulin, you are going to give glucose. In opioids, you are going to give naloxone. In copper, you are going to give d-penicillamine. And in central anticholinergics, you will be giving physostigmine. So yes, we have revised the table now, and yeah, we are good to go for next session. I hope you people understood this session. Completed our general toxicology session, and next session would be on corrosives. And as I say every time, until then, keep learning, keep growing. Bye.